Thank you. Thank you. It's great to be here with you. I'm going to jump right in because limited time. Honestly, 55 minutes is not enough to talk about case selection, but I hope to give you some ideas of how to think about it differently, maybe than you normally do, and some easy buttons, some things that you can look for to make your life simple. Because at the end of the day, it's not really how many cases you start. It's how many cases you finish. And that starts with picking the right cases to work on. So let's get started. When I hear people talk about being a digital dentist or doing digital orthodontics, they pretty much talk about clear aligners. And if you look at how it's been marketed, it's, well, what kinds of cases do you feel comfortable treating with clear aligners? Which seems like an innocent enough question, except for it turns things on its head, kind of gets the cart before the horse. Seems to me what we should be asking is, what's the diagnosis? And once we know the diagnosis, which is more complicated than it's crooked teeth or spacing or whatever, I'll show you that as we go along. But once we know the diagnosis, we say, what's the best way to treat it in the most efficient and therefore profitable way? And is it with clear aligners, or is it with some other modality, or is it with something and clear aligners, which is where most of the cases would fit? So the types of things that I see are aligner alone cases, and really there are very few that can be treated well with just aligners alone. But then if you add things like attachments and IPR, interproximal reduction, and elastics, boy, that shoots up a bit. But even then, there are many cases, if you're looking at a complete diagnosis, that may require something more than that. So an actual palatal expander instead of just expanding the arches, or correcting class. If it's class 2, making it class 1 spaced. If it's class 3, make it class 3 spaced. Those are all very treatable with aligners, and so then you finish up with aligners. Or in many general dental offices, they may use aligners to put the teeth where they want them, knowing that the teeth aren't the right shape or the right color or whatever, and then restore them afterwards. And then you jump up to pretty much most of the cases. There are a handful that are surgical or really complicated. And honestly, I don't think you need to do that to be profitable. So what do aligners do well? You need to know this when you're choosing cases, right? It's not a question of will it work. Of course it will work, but what does it do well will dictate how long it takes to do it or how well it does it. So what does it do well? Well, it rotates flat teeth. If you have an incisor, you can put force on it here and here and cause a moment. That's not as easy to do when it's a round tooth. You can intrude incisors fairly easily. You can tip teeth buccolingually, so you can tip the incisors out. You can tip the molars up if they're tipped in. And you can close anterior spaces pretty well. Sometimes posterior spaces, but anterior spaces are really easy and pretty predictable. What do they do moderately well? Well, rotate molars. You have enough surface area to make that happen. You can intrude posteriors if you do it properly. There are some tricks and techniques to use, but if you do those, yeah, they do have some intrusion force, in fact, better than it would be with braces. You can do some arch expansion, quite a bit of arch expansion, depending on how much is needed, and you can correct some mild crowding, and maybe even moderate crowding if there's arch expansion needed. What does it do poorly? What do aligners do poorly or slowly? Rotate round teeth. You can put attachments on. It's still the sort of thing that, man, if you could just rotate those first in 2 or 3 months with a hybrid case, then it's easy to do with aligners. Doesn't extrude anteriors very well. If you have smile arc issues, you want to address those first with pivots or with brackets or something to take care of that, and then finish with aligners. Doesn't do well with bodily movement. So if the root is out of position, aligners may not be the right choice. if the roots, if you're going to take teeth out, which doesn't have to happen very often anymore, but if you were trying to upright those roots and make them parallel is really hard to do in aligners. Sutural expansion really depends on age. If it's a 6-year-old, yeah, use aligners. They're fine. If it's a 12-year-old, aligners aren't going to do sutural expansion. And if you're an adult, forget it. So it depends where you are in the thing. You can still expand, but you may finish with aligners. Moderate to severe crowding, sometimes it depends on the other factors. And correcting class is forever when you use aligners. You have to do it 2 teeth at a time. You move the second molars back, then the first molars back. Then it takes forever. Okay. Whereas if you do it with some other things, they're done in 3 months with that part, and now you're just moving teeth. So it does depend on the proper mechanical setup, but this is a pretty good. I'm going to dwell here for just a second in case somebody wants to take a photo of this. So my recommendation is stay at the shallow end of the pool. And while these are some of the things you may look for, I'm going to give you some cases to look for. We'll talk through them. It's really how they fit into the total diagnosis. Okay. So mild crowding, mild, even moderate spacing. Relapse cases are great because they put the roots in the right spot. At one time, they were straight. You don't have any tooth size problems. Those are great cases to do. Minor rotations or tilted teeth, you can, especially if the posteriors are tilted in, that's easy to do. If you're trying to fix an incisor that's tilted, that's much, much more difficult to do. And mild dental arch expansion. So you could do most cases with just this stuff. So here are some examples. This one's from Dr. Terry Selke. The young man starts, he's class 1. He's got a fractured upper incisor with some spacing, okay? Real mild spacing on the top and the bottom, not a big tooth size discrepancy. He does have a freedom that comes down all the way to the palate, so that has to be addressed. Now, the one thing that really complicates this one is he's got condylar degenerative joint disease in the left condyle. So depending on your familiarity with degenerative joint disease, you may or may not choose to treat this, but otherwise, this is a pretty simple case to do. And you finish in a great spot and that he's ready for restoration. That's all done really pretty quickly, okay? Severely deep bite. Now, if you look at his smile arc, it's really not bad. What you'd really like to do is bring the laterals down, but that's virtually impossible with aligners alone and even with attachments. So take care of that lower crowding, take care of the upper spacing and reduce the overbite. Okay. Minimal attachments. Well, if you're intruding teeth, you have to have attachments or else the aligner won't stay on. So you'll probably put attachments on the upper first and second buys to give the pressure to intrude those upper teeth. Same thing on the lower. Minimal IPR, because there's almost always a tooth size discrepancy. And in most cases, it's the upper laterals. If you look at this young man's upper laterals, they're narrow relative to the centrals. And so you have a choice. Either you IPR the lowers or you leave space to bond the uppers. Either way will work. And you could make the case for bonding those laterals because they're small anyway. But this is not a bad finish. This is a great finish in a relatively minimal amount of time, but you do need IPR and you need attachments. Here's an adult. He's got a bilateral posterior crossbite that's skeletal. He's got very, very small laterals, big diastema. He's got space behind the upper canines. And at first glance, I'd say, no, don't do this. Well, the problem was he's medically unable to have expansion done. And so because he's not going to have expansion done, we're going to leave the crossbite. Now you're just looking at the anterior teeth saying, can I help him aesthetically? And certainly you can. So in less than a year, they close the spaces except distal to the upper canines. And why are those there? Because the upper laterals are small. They're small both lengthwise and widthwise. So you could make the case for going in and restoring those, tipping the upper incisors forward or closing those spaces and then restoring the upper laterals. But that's a decision after the fact, okay? Because the choice was made for a compromised result, all you're trying to do is close the spaces. Relatively easy to do with the aligners. Here's a situation where you've got moderate spacing in a periodontally compromised person who's missing a couple of lower incisors, okay? And you look at that and say, ooh, that looks bad. There's an open bite and the teeth are tipped forward and so on. But tipping teeth is what aligners do. They do a great job of tipping teeth. So tipping those forward or tipping them back, both are pretty easy. So unless there's a tooth size discrepancy, which there almost certainly is, because remember, you've got a situation where she's missing 2 lower incisors and she's got a bunch of bridges. Does that stop you from doing it? No, because you're not moving the bridges, you're moving things to the bridges. So yeah, that's one you can do. And they did it in 5 months. Can you do it in 5 months on your own? Maybe not. It's hard to know, right? You can, but if you're working with somebody, being collegial with somebody, they can do the setup and help you with it. They can help you go through this. When do you see her? And quite often in a 5-month treatment, I wouldn't see them at all. I'd see them at the beginning and I'd see them at the end, because in between we're doing virtual monitoring, digital monitoring, or the monitoring through another company. You can see this stuff from home, from the beach, from Florida, from wherever. Here's another one, class 1. She's got moderate crowding. You can see she's crowding upper and lower, right? But she's got a little space distal to the upper left canine and mildly small laterals, upper laterals. Pretty straightforward, right? Those upper teeth are going to come forward just a little bit. That's where you're going to get your space for your lowers. Plus, you're going to intrude those lowers just a little bit. You're going to get a little space there. You may have to do some IPR, right? But it's relatively straightforward. And it's a beautiful result, incredible result, right? Aesthetically and bite-wise, unbelievable. So here she is in a short period of time. That's the sort of thing that's pretty easy to do. So where do you find those cases? Well, relapse cases, as I said, they once were straight. Getting them straight again is going to be relatively easy. And if you're looking for it, collapsed arches are a big, big deal. I mean, it's not the purview of this to talk about sleep apnea and what orthodontists can do, but collapsed arches are a big issue. And I will show you a case on how much we had to do in order to get him significantly better on his sleep apnea. We don't want skeletal issues in any dimension. We don't want transverse skeletal issues. We don't want AP skeletal issues. We don't want vertical, right? And within that context, mild to moderate crowding, mild spacing, mild open bites, anything mild at all, even if there's a rotation. Well, we will talk about the 1-tooth exception, because what you want to do is you want to find the thing that's going to take the longest and then make a decision based on that. Everything else can sort of the rate limiting step in chemistry. If everything else is pretty straightforward, but you have 1 tooth out of line, it may be a case you want to pass on. So here's an example of what not to do. Okay. I was an orthodontist I was a practicing orthodontist for 37 years in Michigan. And this is a friend of mine, pretty prominent in the dental world. His name is Elijah Desmond. And technically, I'm not treating him. His general dentist is treating him. I'm collaborating, okay? This is where he started in 2018. And you can see where, you know, from a liner standpoint, it looks pretty straightforward, right? He's got a little bit of spacing. Arches are wide. A little bit of spacing. 5 years and 4 refinements later, here's where he sits. And he says to me, Lou, my bite doesn't feel right. I'm wearing down my front teeth. And what was the problem? Well, After 5 years, you've got a frustrated patient. They're burnt out. They don't want to wear the aligners at all. And they sure don't want to have to wear them again, given that they've failed repeatedly. The profit that you hope to get is gone by doing 5 refinements and seeing them over and over and over, and the stomach lining associated with having that conversation. It's madness. What they didn't do was a complete diagnosis and treatment plan, right? And that makes sense when you look at the photos. You can't. I'll show you that in a second. A complete diagnosis for me means that what is the airway status? Do they have a patent airway? Do we have to do anything orthodontically to improve it? What are the smile aesthetics? We're talking 3 different ways. Skeletally, we're talking about the smile itself, and then we're talking about the size of the teeth, the proportions of the width to the length. We're talking about are the heights of contour a little bit distal on the laterals and on the centrals. I mean, there's a lot of issues that go into smile design, ton of aesthetics. Are we doing that? And are we looking at occlusion sort of like an pathologist looks at? I don't know that we can really be that precise, but we're pretty darn close. And with a mild occlusal adjustment, we can be there. I've proved that. So those all go into it. And if you fix all of that stuff and the skeletal issues, orthodontics is pretty easy. Straightening teeth is easy. So you'll get that as a side effect of doing these things. And then we find a treatment plan to address all of those things at one time and solve them all at the same time. So here's Elijah at his beginning. And what did we miss? Well, he's class 3 skeletal. You can't really see it from the pictures because they're bad pictures. Speaking of which, next Tuesday, I'm going to be doing a presentation on good pictures and bad pictures. If you come to that on Tuesday at 8:30, you'll see the same picture, okay? So he is class 3 skeletal. He's got a short lower anterior facial height, so he's overclosed, small upper laterals, got a skeletal asymmetry. If you look, the occlusal plane is canted, the aesthetic plane is canted, and the chin is off to his left. He's got a posterior open bite to start, which only gets worse when you close all the spaces with those small laterals. So I saw him at a conference. I met Elijah. He's, like I said, very prominent, and he does a lot of conferences, and I've been to his, and we've become friends. And I said, well, the problem is your lower jaw is jutted forward, so of course you're hitting your teeth. That was probably there when you started. And so I just photoshopped this to show him the difference in profile that we could probably achieve. And then I showed him his front teeth, and on the left are the pictures of his front teeth, top and bottom, and on the right was where I photoshopped them, okay? And said, they're too short. They should be longer so that your lower lip matches your upper arch. He couldn't even see that. These are the sort of details we should be fussing, though, as professionals and offering. And if they do like that, then you say, all right, first we're going to fix your bite, and then we're going to fix your teeth. You can see his upper right lateral is a little discolored. I just did a reversal to do the upper left when I extended. That's why it's a different color. So if you do the complete diagnosis, then you have a better chance of winning, of getting everything right, and of having more cases. So you can go it alone, and that's what most of us did. I mean, I got out of school. I went to ortho school at Michigan, and I graduated, and I went into practice, and I started figuring stuff out. Went to a lot of CE. Honestly, good judgment comes from experience, and experience comes from bad judgment. I made a lot of dumb mistakes. You don't have to do that. With the electronics the way they are, and this is a result of COVID, really, things exploded where we can do so many things virtually. And you can collaborate with other people. You can collaborate with restorative people. You can collaborate with orthodontists. Our sponsor has a platform for that. It no longer is try it and see what happens. Honestly, if you think about it, the only reason it makes sense to do orthodontics in a general dental office is if you can delegate most of it. If you're doing it yourself, you're better off doing crowns and bridges and those sorts of things. So you can take advantage of experience virtually. How would you fix this? And so this is my challenge to you. How would you fix this? So when you're trying to diagnose and treatment plan, first look at what's going on and then figure out how is it going to happen? Because if you can't imagine how it's going to happen, then you can't do aligners or braces or anything else, right? And you can't delegate it to some tech in Central America. I'm telling you, you've got to be able to diagnose and treatment plan, at least to a certain extent. So when you look here, let's look a little closer and see. If you look at the upper posterior teeth, they're tipped in as well as the lower posterior teeth. There's a lot of crowding, but if you upright those posteriors through the bicuspids and through the canines, you all of a sudden have more than enough space. And then you start to realize that the upper incisors have been tipped back, and so are the lowers. You can tip them forward a little bit. He's got plenty of attached gingiva of keratinized tissue down there. There's not going to be a problem there. That makes sense, though, because remember, he had braces when he was 12. And now he's sitting here with this arch, with the smile that he's got, and he wants his smile improved. But he's also got an AHI of 52, which is severe apnea. This is Dave Paquette's father-in-law. He treated him. That's where he finished aesthetically. This is what they did. So the upper picture is before, and the lower picture is after. And those lines are the exact same length. The pictures are exactly the same size teeth. That's how much widening happened. We just gave him arch form and fixed the collapsed arches. And he went from an AHI of 52 to an AHI of 14, which is still apnea, but it's mild. If you look here and you think, all right, I'm going to give him an oral appliance, that's a hard oral appliance to make because you've got to get it to fit on those lower front teeth so that it's tight, but it's got to draw, and they're all going every different which way. So it would be justified in doing orthodontics first and then doing an oral appliance as the retainer. This is what we don't want to do. The molars are already upright. They're not tipped in. And we say, all right, expansion is the way to solve sleep apnea. So we're going to expand. And then what we do is we tip those teeth out. They become periodontally unstable. They're tipped out so the occlusion is all messed up. You can't tip the uppers out or the lowers out enough to match the uppers. You've got an open bite and you've got a ton of space. We can do better than this. If this is the case, if it's a narrow maxilla, fix the maxilla. Make it a normal size. Then you'll have space and you can close that all. It'll be space in the front. You can close it in the front with aligners. Piece of cake. It's a hybrid case. So here's an example of somebody who came in and their primary concern is sleep apnea. Okay. And so I look at the profile. Of course they are. They had teeth out when they should never have. She was probably a jaw surgery case from the get-go. The upper jaw is narrow, right? And now she's an adult. Everything's collapsed in, especially the lower anteriors. She's got large tori, which take up tongue space. But I'm looking and saying, how are we going to get draw and retention on those lower anteriors? And the uppers, even though they're narrow, some of it is dental narrowness. If I can fix the dental narrowness, I'm going to make her airway better. Can I do this with aligners? If you look, there's plenty of keratinized tissue, and I'm going to be watching it. It didn't take very long before those teeth are lined up, right? And they're lined up without taking any teeth out. There's plenty of keratinized tissue. And now she's got a little bit more width on the top. So her sleep apnea has gotten better, and we can make an oral appliance for her to bring that mandible forward. That's a viable option now. That will work. What about smile aesthetics? So when you think smile arc, I want you to think of the upper arch how does it look relative to the lower lip? What's that arc look like compared to the lower lip? Really, really important measure. Once you look at the gingival display, and that will change by age. So in a 10-year-old, you should see all of the teeth plus some of the gums, 2-3 millimeters of gums. In an adult, this young lady is 21 when we took these pictures. Seeing all the teeth is great. It's a youthful look. Okay, so it depends on your age. You might, and if you're 80, you will see maybe half the teeth if it's great. But so many 80-year-olds, you don't see any upper teeth and you see just lower teeth. The third part is the buccal corridors. Are the arches wide enough and full enough that they fill the commissures of the mouth? Those are all aesthetic concerns that we should be putting into our treatment plans. And if we do, then we're going to find some tougher cases that you may want to wait on. Or when I say wait on, I mean you may need a little bit more experience or a little bit more training before you're ready to take those on. I know an orthodontist who's teaching general dentists how to do TAD-supported expanders. Okay, so you have options to learn things. It's a question of how much do you want to learn. So the cases to avoid when there's a skeletal problem. So Elijah's case never had to get where it got, right? It was a skeletal problem from the get-go. And what we're doing now is virtually, we did class 3 motion, which is going to change the occlusal plane. That's how you're going to get the profile difference that we talked about. And that's going to open the bite. And it's going to give us a little bit class 3. So we'll have room to bring the incisors up, right? And I'm doing that, believe it or not, with aligners. I'm bringing those lower incisors up. Some of the materials that we have now make all the difference in the world, but it's a difficult movement to make. And then bodily root movements, like I said, if there's an extraction case or if you have to close massive space by bringing the posterior teeth forward, this is probably not the way to do it. Do it with braces. Sutural expansion in a kid that's older than 6 or 7. Okay, you're going to want to do an expander of some other kind and then go into aligners. One tooth issues, I'll show you what I mean by that. And then correcting class you can do it, but it takes a long, long time. And anytime you see severe, I would probably shy away until you have a lot of experience. Certainly starting out, I wouldn't be doing severe cases. So here's the situation. He's got severe spacing. He's got a massive diastema. Everything is tipped forward. He's got a massive tongue thrust. If you look on the upper right, he's got a cant of his occlusal plane. It's hard to know if that's because his lips are being displaced because of the teeth or what's going on. But he's got a tongue thrust and, man, really, really tough case. And she did a phenomenal job. Okay, Yvette Battle treated this case. And she put on permanent retainers, bonded retainers. I would support those with a clear retainer over top of them. Why? Because now the 6 front teeth on the bottom all are attached. They're not going to space, but you're going to get space or movement between the cuspid and the bi, unless you maintain it in some way. And just have them wear it over the fixed retainers at night. Same thing on the top. They held those closed. And you can see those laterals are just a hair narrow. So they closed those spaces. They almost certainly did IPR on the bottom, right? 7 months in retainer, this is what you're seeing. So we're stable. His life has been forever changed. That's one of the nice things about ortho, is you get to see your results and people like coming to you. Nobody ever says, man, I hate to be here, or God, I wish I was doing anything but this. Here's an adult, right? Anterior class 1 crowding, anterior crossbite. The condyles are displaced posteriorly. So she's pushed back as well. So she has clicking and pain. We want to bring her forward, her mandible forward. She's already almost end to end in a crossbite. Plus she's got some pretty substantial rotations. You look at that upper left canine, There's the one tooth exception. That's going to take the longest, but all the other canines are rotated as well, right? But the upper left canine's the rate limiting step in this treatment. So can it be done? Yeah, but I don't know that I would do this as a first one. Or, I mean, remember, Dr. Terry Selke is not only an orthodontist, he's one of the better orthodontists in the world. He maybe have put braces on those upper and lower bicuspid to bicuspid, line those up, get rid of the massive rotations in 3 months, and then go to aligners. He has tools you don't have. Okay. And there's where they finished in 13 months. Right. And now she doesn't have the TMD symptoms that she had. So that's a really good finish, but not the one I would have you do first. How about a teen, right? Late mixed dentition. He's missing some teeth. The upper right five is, or upper right first, second bite is coming in. He's got a diastema. He's a full tooth class too, right? This isn't one that you just move teeth with aligners, and his hygiene is maybe not the best I've ever seen. So he's got a deep bite. We've got to intrude those lower teeth. We've got to move the upper ones back. We've got to do a class 2 correction. That's a lot to do. I certainly wouldn't do it as my first one. But they did a great job in Dr. Mark Lowe's office, right? They used rubber bands. The kid wore them for the most part. They got the midlines almost on, almost class 1 on the left. It is class 1 on the right. If you look at the pictures, you can actually see that it's pretty much class 1. Some of the pictures, you can't see that. No refinements, one shot at it, and he got everything done. This kid must have worn his elastics like a champ. Moderate crowding, here's an adult. Moderate crowding, posterior crossbite, and what I would call a posterior crossbite tendency in addition. If you look at the upper posterior teeth, they are not tipped in. They are tipped out just a hair or stable. On the right, they're stable. On the left, they're tipped out a little bit. The lower teeth are tipped in a lot on the posterior, and that's why you have all that crowding. So what are you going to do to fix it? You want to upright the lower teeth, but that means taking the upper ones and tipping them out. Are you going to tip them out too far? Because you got to go quite a ways. You can't fix the kind of crowding you see on the lower right unless there's visible space between those teeth when you move them, when you rotate them. That lower lateral is not going to come into the arch without space. Where's the space coming from? It's going to come from uprighting the lowers. It's going to come from slenderizing IPR. It's going to come from maybe tipping the lower ones forward, although they look pretty well tipped forward, right? You're going to have a combination of things. There's a lot of moving parts with a case like this. And yet, Efren just nailed it. Just nailed it. You look at the midlines they're on, you look at the aesthetics, it's on. Smile arc is maybe a little flat, but boy, you know, given where we are and what we had to work with, that is a phenomenal result. This one would be borderline, okay? If you look at those lower anteriors, they are all crooked, and the lower right central is tipped out. You need to have space to bring them forward. You have small upper laterals. The midlines are on, everything else looks good. But if you look, the upper bicuspids are tipped in relative to the canines. And so are the second bis, and so are the molars. So where do we get the space? Well, we tip those teeth out. We leave the second molars where they are, tip the rest of those posterior teeth out, which allows you to upright the lower posterior teeth, which then gives you space to align those anteriors. And you might do some IPR because you've got the tooth size discrepancy with the small upper laterals. And in 11 months, Dr. Terry was able to do that. Okay. Wonderful result. How about a situation like this? Looks like they've had ortho before. They've got a fixed lower and upper retainer in, and you can see the lower teeth are in crossbite. Midlines are on, but there's a ton of space on the lower, and The teeth are in crossbite. She's a little bit super class 1 on the right. No overjet. She's hitting end to end. And if you look at her lips, she's got a lower lip is averted because it's tipped forward, trying to match those teeth. She's also missing a lower posterior tooth. That's one. Remember, we said moving teeth, moving the roots through bone is a very difficult movement with aligners. I wouldn't try that with aligners. So what they did is they didn't aim for that. They left the space for a restoration down there, but they did everything else. And by skewing the arch, I'm going to go back. By skewing the arch, taking the space, moving the incisors back, but also it's going to be a combination movement where the cuspids come back and rotate. That lower right bicuspid and cuspid come back a little bit so that they're not super class 1, so that they're class 1. All of that can be done, but you have to visualize this at the beginning. And my challenge is, have you done enough cases that you can actually visualize that? And if you haven't, I would punt this one. I would have somebody do it or do it in collaboration, because then you could do it, right? And he did a phenomenal job. Great alignment. The upper arch was expanded slightly. He has a space for the restored tooth or the tooth to be restored. Crossbite's been corrected, the whole thing. Really beautiful result. So avoid skeletal problems. Here's a young lady. This is one of my patients. The upper second bis were impacted and she's class 3 looking, right? This is one to try and do this with aligners. What a nightmare. Not worth it. We used class 3 motion. We corrected the class right away. We ended up extracting the upper second bis. Then we put braces on and lined everything up. She was done in a good, easy portion of time. But I mean, my goodness, to do this with aligners, just to bring that lower left cuspid up and rotated is going to be a nightmare with aligners. This is one I would punt. Elijah's, you want to extrude those anteriors? 2 problems with that. The gingival heights are where they should be. The teeth are worn. So if you bring them down, then what you have are the gingival heights out of whack. Probably doesn't matter. This wasn't a natural smile, but it wouldn't matter because I don't think he would show them. But it's so much better to just restore them to the normal length, right? And I wouldn't even spend an ounce of time trying to extrude them. I would intrude anything I needed to intrude to get the gingival heights exactly right, and then restore them back to a normal length. So bodily root movements, extraction cases, are cases where they're missing teeth. Severely tipped teeth, not buccolingual, but I mean, the upper incisor is tipped 10 degrees to the distal. The root's in the wrong position. No, don't do it. Sutural expansion. So you look at this, we have a 1-tooth exception. Everything could be lined up pretty well, except for that 1 tooth. But if you look at the back teeth, the lowers are tipped in severely. The uppers, not so much. The upper jaw itself was narrow. And she's an adult. So we did a TAD-supported expander, which got us a ton of space. And because of the rotation of that tooth, we used braces. Trying to do that tooth or that lower left canine with aligners is doable. It just takes a long time. If you can do, and I'll show right at the end, I'll show you what pivots are. If you can do it with pivots or with brackets, just for a short period of time, most patients will accept it. Depends how you present it, but most patients will accept that. And you get done in a reasonable amount of time. So 1-tooth issues. If you've got that 1 tooth in the upper right, that 1 bicuspid that's rotated 90 degrees, you're going to rotate a cuspid 90 degrees, a round tooth 90 degrees in aligners. That's going to take a lifetime. On the lower left, that cuspid and the upper left first bi, very difficult to do with aligners. That canine that's highly impacted in the upper left, right? You can bring it down. I mean, orthodontists do this, and you could learn to do it, but man, That is a lot of work for something that there's a million cases without doing that. You can do easy ones without having to even think about those. And correcting class. Here's an example I was talking about where you used motion, and in about 4 months, he went from being a full tooth class 2 to, we rotated the upper molar, we opened the bite, we changed the lower molar. I mean, there are a lot of things going on. We've got him class 1 cuspid with spacing on the upper. Right? At that point, yeah, you could probably use aligners to finish. So correct the class first in 3 months while they're willing to wear rubber bands. Don't wait to the end. And don't tell them you're only going to have to wear these rubber bands for all the time you're in aligners. Do the class first and then do aligners to finish. So take-home messages. The first is start with the diagnosis. And diagnosis, I mean, I do a 2-day course on sleep apnea and ortho. So there's a lot of material to learn on aesthetics. There's a lot to learn on airway. There's a ton to learn on occlusion. Keep going to CE and get the knowledge you need to know all of those things, and then figure out what it is you want to do, and then figure out how you're going to do it. So it may be motion to take care of the class 2 or some other class 2 correction. It may be an expander of some sort to fix the skeletal transverse problem, and then use aligners. Then it makes all kinds of sense. So the hybrid approach, in my mind, is the way to go. Not only from a better treatment result standpoint, but from a being able to treat more cases standpoint. And you don't need to go it alone. You can collaborate. So here's a situation. Patient that was referred to me, just as sweet as could be. These are the pictures I got. These are the ones that were submitted to the aligner company back in the day, and came back with a treatment plan. And so I would say, what do you see? But honestly, from these pictures, I can't see a whole lot. I mean, the pictures are horrible. And you'll see this one as an example of what not to do on Tuesday. But there's your smile. And the thing that strikes me is the midline is off, even though we're taking the picture from the more of her left side than the right. It's not a true picture, true clinical picture, but you can see it's canted up on the left. This is a pretty complicated case. And after 5 years and 4 refinements in a general dental office, she comes in and says, this is where I am, and I want to have the best smile I can get. I don't want to do surgery. I don't want to do a special expander for adults. I don't want to do any of that. I don't want braces. What can you do? And I have this thing going on with some bone loss on some teeth. What can you do? And I'm saying, well, that lower right central is compromised already. Maybe we should take that out. I know we're not going to fix the crossbite completely. I just know, I can tell without doing a skeletal expander, not going to happen. Lower arch isn't horrible as far as alignment goes. So I have to start with, we're not going to get there. We're not going to get to perfect, okay? And it's not going to happen in one fell swoop. But if you look at the rotations and ins and outs of the upper arch, something has to be done. And if I do it with aligners, it's going to take a lifetime. So what we did was we used pivots. And pivots, you can actually print these in your office if you got a 3D printer really easily. They are attachments for aligner cases that have an arch wire slot through them. So they have an 016 slot. So you bond them on the teeth and slide a nitinol wire through there, and it starts taking care of all the rotations and all the ins and outs and all the ups and downs and to a certain extent, the smile arc. In this case, I've got a limited, I mean, this looks a whole lot better than her smile as far as the cant of the occlusal plane. That's why you need facial photos too, okay? And in retrospect, I should have gone back to the second bias on the top. but I didn't. So we had to fix those in the aligners. So then I started seeing things that I had to do. I had to add a button on the buckle of the upper left 3 so she could wear a rubber band down to the 3 and 4 on the bottom, in addition to doing the aligners. And I told her at the get-go, we were going to do this, we were going to have at least 1 refinement, maybe 2, even though she'd been through the ringer for 5 years, we were going to get there. So you can see we improved the smile arc. We didn't get it perfect. We improved the cant dramatically. We improved the alignment dramatically. This wasn't when she was done. This was when she was in her final adjustment. But that was the difference between having a plan and using more than just aligners, right? Doing a hybrid case. This is what we were able to accomplish in about 11 months. So I'm done with the formal part of it. I wanted to aim for a few minutes of questions. I'm going to leave this up. This is my contact information. If you want to ask me a question offline, feel free. That's my direct email address. And then if you want to have a conversation, you can scan that QR code or type in the Calendly number. We have a website. It's called Egghead Ortho, but we're rebranding. That's why the slides look different. That's our old logo, and up above is our new one. You can type questions in the Q&A, or in the chat if you want to. Anyone have any questions? Actually, they're called pivots, and you can get them through Braces on Demand, but you got to have a 3D printer to get them. Well, no, you don't. You could have them print them for you. That'd be fine. Do treating TMD patients with ortho worsen their conditions? Not the way you've answered the question or asked the question. I always say ortho doesn't cause TMJ problems or TMJ solutions, ortho by itself. So if you think about it, 2 of those that I showed you, both by Terry Selke, one of them had degenerative joint disease, and the other one was a true the posteriorly displaced condyle. Both of them got better with ortho. The thing is, you want to make sure that you do good ortho. So what I always said was, bad ortho, yeah, can worsen the condition. Doesn't mean it always does, and doesn't mean that if they have a problem, it's because of the ortho. That's a step too far. But good ortho can make it better. It's the principles behind TMD and why do they have it. Is it a muscle problem? Is it a skeletal problem? Is it a joint problem? What is it? Do a really precise diagnosis of it, and then design your treatment to fix it. You have to place them as you would brackets for the pivots. I'm sorry, the question is, how do we decide pivot placement? Do they come with a guide? They don't. You have to put them on, but you may be able to do them indirect bonded. I'd have to ask that question. I'm sure they can, whether they can right now. The designer is an abject genius, and he could probably have it designed by tomorrow, where you could do it indirectly. And you can do brackets indirectly through them as well. Can we extrude tooth numbers 10 and 11 that have 4 to 5 millimeter of recession? If yes, would they need root canal? Thank you. First off, almost impossible to extrude incisor teeth of any kind, any amount. Okay, and so to do it 4 or 5 millimeters, no. That's madness. Don't do that. Do it with braces or refer it, right? If they have 4 or 5 millimeter of recession, then what you're doing is you're extruding them to try and improve the pocket. It's sort of the Kokich and Spear approach to fixing pockets. So you bring the root out more. you're going to then have some other issues. 4 or 5 millimeters, it depends on how big the crowns are, but I suspect you're going to need to do root canals, post a buildup, and some sort of crown on them, because the further you go up, the narrower they're going to get. So you're going to be at a point of the upper, I guess, right incisor, right lateral, where it is past the height of contour. So my suspicion is the answer is number one, don't do it, not with aligners. Number two, if you do it, you are going to have to do root canals and a buildup on number 10 and possibly number 11. Is intruding anteriors relatively predictable with aligners? When done properly, yes. Okay, to just put the aligner on without anything else, probably not. But and it depends which ones, if you want the uppers or the lowers, and where you put the forces. But absolutely, can be done and can be done fairly reliably. Thank you to all of you for taking time out of your evening to be here with us. I appreciate it. Thank you.